First off, thanks to Ken for an awesome talk. That was really incredible. And I also want to thank your parents for being such strong advocates for you. And what I'm going to talk about right now is sort of what I've sort of picked up at the newest or the latest NF conference. And these conferences are really a direct result of parents of, just as Ken has described, I mean, parents who are advocating for their kids, who then created this foundation that has pulled together the research community from around the world and has been getting together on an annual basis since the 80s and really has changed the landscape to the point where we are right now, which is right on the verge of a variety of new medications, new therapies, which, this is sort of it's a paradigm. In medicine, we frequently call a paradigm shift. We're right at the cusp of a totally different way of approaching NF. And in the last, Ken and I share the fact that we're both 50. So in the past 50 years, using that as a landmark, from going from NF being called the elephant man disease to having novel new therapies that can be used to treat the symptoms of NF, and even the concept of potential cures on the horizon is very exciting and really a direct descendant of parents like Ken. So thank you. So just a little bit of background. So Children's Tumor Foundation supports this national conference that happens every year. Every year it's in a different place. It used to always be in Vail, Colorado, back in the day when the conference was quite small. So when I started in NF in 2002, the research community would get together and talk about all the science that was happening to understand the biology of NF and how the disease happened and what therapies might someday develop. But it was really at a very basic science level for the most part. And initially, there were probably about, I think at the first meeting, I think there were something like 20 people. And now there are hundreds and hundreds of researchers from around the world that come together to talk about what's going on in the community. So it has been a remarkable amount of growth over time. And that's due in part to CTF. It's also due in part to money that the Department of Defense puts towards NF research. They spend $15 million a year on research. So a lot of these researchers are funded by the Department of Defense or by the NIH as well. Since our last meeting, we've actually had two conferences, so I'm going to briefly just touch on some highlights of the two conferences. The 2018 conference was actually a joint global conference, so there's a European or international NF group that joined the CTF group, and so it was a larger conference in Paris, and we're going to have joint conferences like that on an intermittent basis. And then we just had our more recent 2019 NF conference in San Francisco, California. This isn't directly about those conferences, but just in general, some of the new things that are happening in NF. We're understanding the genetics of different forms of NF much better. Genes have been discovered for schwannomatosis, and the overlap between NF2 and schwannomatosis is being understood much better than it ever has been before. NF1 and differentiating NF1 from other related disorders has also been aided by improved genetic testing and genetic technology. All of this has led to re-examining what we use to diagnose people with NF and change the diagnostic criteria. So we'll talk a little bit more about that. We've also been learning more and more about the genotype-phenotype correlations of NF1, meaning if you have a specific mutation in NF, what symptoms does it lead to? And that's always been a really challenging area, and slowly, bit by bit, we're understanding more about that, so that can be helpful. Genetic testing is getting better because of next-generation genetic sequencing. We are also learning about treatments, like MEK inhibitors in NF1 and Avastin in NF2. And we're also learning a lot about the risk of cancer associated with NF. So these are sort of topics that have been hot topics in NF the past few years. Probably the hottest topic and the one that gets the most airtime at the conferences and in general are the new therapies. And in our individual session, NF2 session and NF1 session later on, you'll hear more about the new therapy. So I'm not going to spend too much time talking about it now, other than to say that we are very excited that the first drug with a specific indication for treatment of anything in NF1, but it's going to be first plexiform neurofibromas in NF1, should be approved by the FDA formally in the first quarter of 2020. And I think this has the potential to really change how we are managing our patients and how we're approaching both the diagnosis of NF, because it's going to be more important to diagnose early, and how we follow patients with NF, because we are going to need to know about tumors earlier on, because we're going to be making decisions about putting people on some of these new medications. I'm sure most of you have seen these pictures before, but these are kids that have been treated with MEK inhibitors with clear reduction in the size of their plexiform neurofibromas. And like I said, more on that to come later on today. Other things that our increased knowledge and understanding of these diseases has led to is re-examining how we manage people with NF. And this past year, in the past 2 years, we've had new guidelines come out for managing the health of kids with NF, and for the first time, a document describing how to manage the health of adults with NF. I'll be talking more about that in the NF1 session later on. Both of those were for NF1. And then the American College of Medical Genetics is coming out with their own genetic counseling recommendations as well. Another thing that happens at these conferences is there are mini conferences within the larger conference, and one I just want you to know about is something called RAINS. RAINS is a group of both patients and physicians and researchers who get together to try to improve clinical trials for NF and try to basically standardize the way that we measure whether or not a medication or treatment is working. That may sound kind of esoteric, but it has really improved our ability to do many clinical trials more quickly and more accurately and get better data from clinical trials. So it's been really important. And one of the really cool things about it, and one of the things that's really helped it develop as well as it has, is that it has a big focus on including patient representatives within the decision-making around what diseases or what aspects of NF get approached. How do we prioritize which symptoms we're treating, and which ways of measuring treatment actually make sense to patients. So if anyone is interested in learning more about that and potentially getting involved in that, you feel free to find me at any point today. It leads to another big issue is not the right word, but another big focus of what we talk about at these meetings is how things are going with clinical trials. And for the past 8 years or so, there has been a neurofibromatosis clinical trial consortium. This is a group of initially 14 centers, and now it's up to 20-something centers across the country and Australia, where we basically unite our resources with funding from the Department of Defense to run clinical trials at a national level more quickly so that we can test a lot of these new ideas and new drugs that are coming out in clinics around the country, which expands our ability to recruit patients and to move things along quickly so that we can not only find potential treatments, but then improve our ability to do that safely and with less side effects. So NYU has been a member of the consortium thanks to Dr. Allen for about 6 years, 5-6 years, something like that. And I think we're probably the biggest contributor of patients being part of those clinical trials of any center in the country at this point. All right, so one of the most controversial and biggest deals at both of the last 2 meetings was a discussion about revising the diagnostic criteria for NF1, NF2, and schwannomatosis. So historically, NF1 and NF2 and schwannomatosis the diagnosis is made on clinical criteria. So examining patients, you see certain features and you can make the diagnosis. And that is still going to hold true, but because genetic testing is now more available, genetic testing is going to be a bigger part of the diagnosis. You can still diagnose someone without genetic testing, but prior to now, it wasn't even included as part of the diagnostic testing, which meant that insurance companies could say they didn't really want to pay for it because it isn't part of the testing. So we're actually hopeful, and one of the main reasons we revised the diagnostic criteria is to help people actually get insurance to cover genetic testing. I definitely don't want to go into it in too much detail here and now, but one of the most controversial aspects of revisiting the diagnostic criteria is that over time we've learned how different NF1 and NF2 are, and the third type of NF, schwannomatosis, is much more similar to NF2 than to NF1, and there is a move to rename NF2 to make it more clearly separated from NF1, and that is probably coming in the next year, where NF2 will have a new name, and what that name is not yet been decided. One of the other exciting things that was presented in both conferences was more in-depth look at specific mutations in the NF genes that might predict outcomes. Ludwig Messiaen is a geneticist who runs the best genetic testing lab for NF1 and NF2 and schwannomatosis at University of Alabama, and they've been collecting tons and tons of clinical data to associate with the mutations, and are basically every month they've been coming out with a new paper that sort of better elucidates the connections between specific mutations and specific symptoms. This isn't to the point where everyone needs to get their genes tested because it's going to change how we manage them, but at some point we may get to that point, but it's in process. In the world of science, we can move things along more quickly in terms of identifying new potential treatments and understanding disease better, frequently by using animal models. And historically, the animals that we tend to use the most are mice. We don't use guinea pigs, despite the fact that that's part of our lexicon. So mice basically can be engineered to have NF1 or NF2 or schwannomatosis, and then you can test drugs or treatments. Mice, as you might know, are not the same as people. And in fact, they are quite different in many, many ways. And so it's hard to know sometimes if you treat a mouse with NF1 and it gets better, if that will work in people. So there's always attempts to try to make better models that are more predictive of how a particular experimental treatment would work. And Children's Tumor Foundation has funded 2 different groups to develop pig models of NF. Pigs are actually, in many ways, very similar to humans. And I'm not just talking about specific politicians, but but all of us. And they're both in terms of size, which is a big deal. So if you're trying to get a medication to a specific tumor, in a mouse, a tumor might be tiny. And who knows if a drug is going to get into it if it's human size. And so in pigs, you can actually do things like that. So these 2 models seem to mimic the NF1 disease pretty well with development of cafe au lait spots and neurofibromas, both on the skin and internally, and optic gliomas. And they are currently treating some of these pigs with MEK inhibitors to see if they can see improvements in some of the symptoms. So this may offer a new way for us to examine both how NF1 works and also what treatments might work better for it. There are no pig models yet for NF2, but I wouldn't be surprised if at some point we head down that path as well. In the past couple of years, there's been a big push to switch research interest towards cutaneous neurofibromas as well as other neurofibromas in NF. So the skin tumors in the past have gotten very little notice, in part because they don't cause medical complications in the same way. It's more cosmetic than it is medically dangerous. But obviously, they can be a very big deal and very important to try to address medically. So Lou Lay is a researcher down in Texas, and Pierre Volkenstein in Paris, and both of them have been working hard to better understand the biology of the skin tumor so that we can potentially come up with therapies. We have gotten new information about how neurofibromas change over time, in part because of better imaging with whole body MRI. So we can now scan people from head to toe and follow them over time. And this is giving us new information about which tumors are the ones that we need to be concerned about, which ones can we feel confident that they won't change. And also just what do these tumors do over time? And one of the most interesting things that this study showed, it's a small study, but they looked at whole body MRIs over several years. And actually many plexiform neurofibromas shrink by themselves without any treatment at all, while others grow. And so we didn't know that before. And now we know that. Now we need to know more about that. Why do some grow? Why do some shrink? Can we figure out which ones are more likely to grow and which ones are not? And also that has important implications for when we do clinical trials. We don't want to get faked out by the fact that tumors might shrink on their own. So we have to take this into account as we design clinical trials going forward. As I mentioned before, you'll hear more about selumetinib and MEK inhibitors when Dr. Allen talks in the NF1 section, but these drugs have shown pretty significant reduction in the size of neurofibromas. But now we're starting to look at these same patients that got treated to see if it treats other aspects of NF. One of the things that people have looked at is the fact that motor functioning in kids that have gotten treated for plexiform neurofibroma improves, that may be something else that we need to look at further. And there's improvement in pain and function for these kids. And it's probably not just related to shrinkage of tumor. Let's see. There was another trial presented basically of using MEK inhibitors in adults. The initial trials were in kids, and the best responses so far we have seen have been in kids, but there is evidence to show that we can shrink tumors in adults as well. The amount of change may not be quite as significant, but there's a lot to learn in terms of timing, which drugs to use, and in which patient populations we should be using it in. There was a trial presented on using Simvastatin, which is a cholesterol drug, for treating autism behaviors in kids with NF and autism. There was an increased incidence of autism or autism-like behaviors. And there had been interest in looking at learning disabilities with these drugs in the past. And there was a big trial many years ago that didn't show any benefit. But this was a smaller trial, re-looking at this same drug, and saw some behavioral improvement in a subset of children with autism. It was a very small trial, but something worth following up on. At these conferences, new sort of therapies that are unproven, very early stages, are also discussed. One of the ones that I found most interesting is the concept of using something called HIFU, which is high-frequency focused ultrasound, so using sound waves to actually heat up tumors from inside, which then may slow down or kill tumors. And so this is something that is in the very, very early stages of being looked at. It's actually used for uterine fibroids already. And there's reason to think that that this might be something that we could use effectively for plexiform neurofibromas, but too early to say yet. Another exciting area in science in general is gene therapy and gene replacement therapy, and there's been a lot of interest developing, actually particularly for NF2 recently, but also NF1. Verena Stedke from Hopkins presented a feasibility study basically developing potential viral vectors to deliver gene therapy. So very early stages, but this is something that we'll hear more about in the coming years. We've also been learning about, sorry, I've gone over, so I'm going to go quickly through the end here, but we are learning more about the clinical features of NF2 and the fact that many people with NF2 have what's called mosaicism, which means that not all of their cells have the mutation, but just part of their body or some of their cells have the mutation. And it turns out that those patients tend to have a much more benign course and actually have almost no chance of passing it on to kids. So that's an important piece of information. These same drugs that we're using in NF1, we heard about some preclinical data, so data in cell models of NF2, that these drugs may also have relevance for NF2. However, there seemed to be a tendency to potentially develop drug resistance in some of the cell models looked at, and for at least one of the drugs, so trametinib. So we're learning whether or not NF2 could be a candidate for using these same drugs that we're using in NF1. And then finally, and we'll hear more about this in the NF2 section, but Marco Giovannini from LA presented some data on early, I guess I was dictating this, gene therapy. It's GENE, not blue gene therapy, for hereditary diseases, and that this, I think, has a lot of potential promise. And vectors are being developed, so ways to deliver these gene therapies are being developed in the lab right now. So this is a very broad overview and just sort of a few random things that I think were of interest, but I think it's really reassuring and exciting to know that so much is happening within the NF research community. And if there are any questions about any of these specific studies or any other studies, you want to come find me during the day, I'm happy to talk to you about them in more detail. So thanks very much.
Good morning, everyone. Thank you so much for having us. We're thrilled to be here to present to you on the topic of talking with your children about NF, exploring the why, when, and how of discussing a genetic disorder. And we'd like to thank our keynote speaker for introducing the importance of this topic. And so we're going to get into it in a little more detail. So what makes this topic so difficult? What makes talking to your children so difficult? As a parent, your instinct is to protect your children. So when it comes to talking about difficult things, it's really hard to want to do that and to know the right way to do that, where you feel like you're able to give difficult information and still protect your children from scary things. A lot of parents feel uncertain and insecure about when to start this conversation and how to do it. Perhaps that your child was diagnosed at a young age and you're unsure of how to approach it because they're young and maybe you think that they're too young to understand what's going on. Perhaps as a parent, you're still coping with this news and trying to wrap your head around it, but then having to talk to your child about it at the same time and how to do that. And maybe you're wondering how this information might affect your child's self-esteem, their ability to cope, and their anxiety moving forward. So our objective today is to offer guidance around the importance of including your child in a conversation about their health and to empower you as the parent to approach your discussions in a way that will set them up for positive coping.
So despite these conversations often being difficult, there are many reasons why we recommend creating an environment of open communication. Children are incredibly observant, as we all know. They notice a whole lot more than we give them credit for. They're very much in tune with the emotional cues of their parents, and they also can tell when there's something different about their childhood that sets them apart from their peers. When children are not given direct information about something, or when they sense that there's something that's not being spoken about, they can come to believe that that topic must just be too terrible to talk about. And it's only natural that they will fill in the gaps with their own explanations, and what they believe, what they come up with in their minds and their imaginations is often much worse than the reality. At our setting at NYU, this becomes especially important, where children with NF are treated at a doctor's office where the words Children's Cancer Center are displayed everywhere. And we certainly wouldn't want children to believe that they have cancer simply because they're never told otherwise. And not only do secrets create anxiety for children, but we've also heard from parents that keeping secrets can add to their stress as well, and that things just become much easier when they're out in the open. Children also have a right to know what's going on with their bodies, and they can feel deeply hurt if they feel that they've been excluded from something that so directly affects them. And when you involve them, you show that you trust and you value them. And not only do children have a right to know, but they can handle this kind of information about their bodies and about their health, especially when it's presented in a compassionate and appropriate way, which we'll be speaking about in more detail. They're much more resilient than we often believe.
So as Jessa pointed out, informed children cope better. When they don't know what's going on, there's the fear of the unknown, which creates a tremendous amount of anxiety. So being open and honest with your child will decrease their level of anxiety. It also will help this information become their normal, as opposed to being something that's off limits that they're not allowed to talk about at home, which again will increase those levels of anxiety and create a lot of fear. It will also increase their cooperation and compliance when it comes to doctor's appointments. When children understand the importance of being at the doctor and going through various parts of their appointments, even if it's a threatening procedure of some sort, understanding why they're doing it and why they need to be there helps them get through it and increases the coping that comes along with it. By giving the information, you're sending a message that it's important for them to understand their bodies and that their bodies are not something to be ashamed about, which will help build their confidence. And along with that comes being able to talk to their peers about it. And so when they understand what's going on with their bodies and they have the information that they need, they're then able to communicate that with those who are asking them questions, and they'll know how to answer those confidently. You're also sending a message that it's okay for them to take an active role in their healthcare journey. You want to empower your child at a young age to advocate for themselves, to ask questions, to take an interest, which will set them up for success as adults navigating their way through healthcare.
So you might be wondering when to start this conversation, and the answer really is that as long as it's happening, you're on the right track. There isn't a magical specific age where we recommend sitting down and talking to your child about NF. We often hear from parents, oh, my child is only 2 or 3 or 4, they're just too young to understand. But it can and should really be something that's spoken about throughout childhood, starting at diagnosis, starting at the first doctor's appointment. Of course, the words that you're using to talk about NF are going to change and evolve as your child grows, but it's never too early. And in fact, starting at the outset makes it so that it's just something normal that's always spoken about. It doesn't need to be something to disclose in a formal way later on. But on the flip side, if talking about NF from the beginning has not been your approach, it's never too late to initiate conversation. And we'll be talking next about how exactly to navigate those conversations. But the most important thing to note here is that this is an unfolding story. It's not a one-time conversation. It's not something that you bring up at the dinner table and then put in a box and put it aside and never revisit again. Repetition is really key to helping children understand their diagnoses and creating a comfort level and normalcy around talking about it. Your child will be, of course, better able to understand information at a more complex level and have different questions as they grow, and so the conversation will change as they get older. And therefore, we recommend creating opportunities for regular times to check in and talk about this, and depending on your family's communication style, you'll know when best to plan those conversations.
Okay, so now we get into the how. Today, we're not going to get into the specific language to use because for each of you with the age of your child, it might sound different given their age and how much they know already. And so we're going to be a little bit more general than that, but this is getting that conversation started, knowing the direction maybe to go in, and being able to at least wrap your head around having that conversation. The first thing to realize is that you shouldn't be afraid to have this conversation. As the person who cares most about your child and who knows your child best, you are the right person to be having this conversation. Find out what they know. That will help start this conversation in an easier way, because perhaps they don't know anything, but perhaps they've heard something, they've picked up on things, and that's how you can get this started. It's also a great way to correct any misconceptions they may have. As we've been saying, they may kind of pick up on little things and start to imagine more than that, and this way you can correct what they're thinking to actually make sure that they know facts. Don't overload them with details. Give a little bit of information at a time and let their questions inform you of what they want to know. You'll be able to read your child's cues or understand from even them saying straight out, this is enough for today, I need to process this. And since you know your child best, you will know when that is. And so giving them a little bit of information at a time is going to be important, to not overload them and to give them their space to be able to understand and come back to you with more questions. You want to make sure that all the information you're giving is honest and accurate. You don't want to sugarcoat information. You don't want to beat around the bush. You want to make sure that you're giving them the real facts in an age-appropriate way, and again, in a way that's not too much at one time. And then maintain your positivity and love. Give lots of hugs during your conversation. It's important to know that this is hard and you're there for them. And positivity doesn't have to mean that you are saying, but don't worry, everything's great. Because this is hard, and there's a lot of really tough parts that comes along with this, but it means that you're finding ways to make the situation better and focusing on what the positives are. And that might mean that you're offering to bring your child to some support group or to meet other families. Maybe it's focusing on the positive things that are happening in their life that outside of their NF diagnosis. And so you're not just focusing on the hardships, but there's a lot of positive that you could be focusing on as well. And your conversation with your child does not have to be perfect. Keep in mind that it is hard. We know that, and we recognize that. And you're going to be having this conversation a lot. You're going to be having this, you're going to check in, they're going to be asking questions, you're going to be revisiting this. And so each time you have this conversation, it's going to give you another opportunity to present the information possibly in a different way. So if you think, well, that first conversation really didn't go well, I wish I would have said this differently, I wish I wouldn't have said this, you have that chance to correct it. So it doesn't have to be perfect. And here's some things just to make sure to include in your conversation. It's really important to make sure that your child knows that it's not their fault that they have NF. We find that a lot of kids, especially the younger ones, 4, 5, 6 years old, might think that they did something wrong, and that's why they have this diagnosis. No matter what the age, it's really important to make sure that there is nothing that they did to cause this. And it's nothing that their parent did to cause this. Having a genetic disorder means they're not the only one, and so it's not their fault, it's not the parent's fault. They have brown eyes, they have brown hair, they're born with this. It's also important for them to know that NF is not contagious. They can't spread it to their friends. Nobody spread it to them. It's not like having a cold and having germs where they need to stay away from their friends and cough into their elbow. It's not contagious. No one can spread this. Make sure that your child knows that they are not defined by their disorder. There are so many other parts of life, and while there are a lot of hardships that come along with it, that they should also be focusing on the positives. And make sure they know that it's okay to have the big feelings that are coming along with learning this information. It's okay to be sad or scared or angry, and that sometimes you feel that too. It's really important for them to see that their parents feel those emotions as well. So we don't want to say, don't feel like that, it's fine, you'll be fine. But to say, it's okay to feel that way, and here's how we can express that. And then there are also other positives that we can feel as well. And when you're having this conversation, if your child asks a question that you don't know how to answer, you just don't have that language, it's okay to say, that's a really good question. I don't know. Let's find out. but you're telling your child that their question is important, and you're also not put in a position where you have to sort of make up an answer on the spot, but they want to know that you're taking their question seriously and that you're going to find out the answer, and maybe it's something that you can learn together.
We wanted to carve out some specific time and space to talk about teens, as of course they have unique needs. As many of you who have already parented teenagers or are in the process of getting your child through adolescence, you know that teenagers are at a vulnerable stage where they are exploring and developing their identities, and having something about themselves that makes them different can often be the worst thing to a teenager. I think as our keynote speaker shared about his own experience with such honesty and vulnerability, you can help your teenager to navigate this difficult phase. You can help to highlight all of your teenager's other strengths, talents, interests, the things that they're good at, the things that make them, the things that make them special, and help them to see that having NF is only one part of all of those other important pieces. And as your teenager is going through this difficult phase, they're bound to encounter really intense feelings, fear, anger, worry, self-doubt, often directly targeted at their diagnosis. And we encourage you to be there with them to help them ride out those feelings and create a safe space to connect so that they feel less isolated and better understood. It's also important to note that it can be really difficult to think about how to bring NF into a social setting, how to tell peers, dating partners, classmates, how to face questions and staring, what to do with all that. And you can help your teenager to navigate that process too. Most kids benefit from having a script, a couple of sentences kind of memorized, ready in mind, so that when they are faced with these conversations, the language is right there. They're not caught off guard and fumbling to find the words. And that can just be, a couple of sentences to explain what NF is, why their friends are noticing differences, but also how to shut down the conversation and respectfully decline talking about it when that feels more comfortable too. Role play and rehearsal at home can help to build confidence, to practice confident body language, a confident tone, so that these conversations can be handled in a really dignified way. And the important thing also is to empower your child to know that it's their body, it's their right to control the conversation. It's up to them to decide who they trust, who gets to know, at what level of detail they get to know. And also that they have a right to not talk about something that might feel more personal, and to come up with ways to navigate that so that they can protect their privacy.
But the most important thing to know is that you're not doing this alone. You have an entire team of staff at your disposal to pick their brains and ask questions to. As child life specialists, our job is to help educate patients about what they've been diagnosed with, explaining it in age-appropriate ways, which will increase coping and decrease any trauma that comes along with learning this tough information. So that is what we do at the clinic every day. We can help you navigate through those tough conversations, help you get it started, answer any questions you might have, and give you the language that you may be wondering about to be able to have this conversation given the age of your child. Our staff can also connect you with resources and services in the community, whatever your child needs to be able to thrive. And so we have a little bit more information about what some of those online resources might be.
Yeah, we wanted to point you toward a couple of resources that could be helpful in navigating these conversations. So the Children's Tumor Foundation has a library of educational resources geared specifically for kids, including comic book characters. We added a little graphic here so you could get a sense of what that looks like. As we mentioned, we are not today talking about the specific words to use, but these resources do have some really nice modeling of language that you might use, so that those resources are kind of make it more fun for kids to learn facts about NF. NF Buddies is a resource that is more appropriate for younger kids, school age, preschool and young school age, and it really helps to normalize the experience of having NF in a really nice way. And then the third resource here is a guide for parents to consider how they're supporting their child in living with NF throughout childhood and adolescence, and it has a really nice way of dividing the information across developmental levels. So we recommend those if you're looking for a tool to help you in these conversations, and we can certainly help in clinic to help you to access these resources as well. Yeah. So this is our contact information here. We welcome you to reach out if we can be of any help in supporting you and your family. And we're at clinic too, so you can find us there in person. Yeah. Thank you so much. We appreciate it.
Okay, so I'm going to be talking today about two procedures called in vitro fertilization, IVF, and preimplantation genetic testing, PGT. So these are reproductive procedures. And just to start off by defining our terms, IVF stands for in vitro fertilization, and in vitro means outside of the body. Fertilization involves the creation of embryos using eggs and sperm. So IVF is basically the creation of embryos outside of the body. And then PGT, preimplantation genetic testing, is genetic testing that can be performed on those embryos prior to pregnancy. So overall, what we're going to be talking about is creating embryos in the laboratory and testing them prior to a conception. And specifically, the terminology that we use when we're talking about testing for NF or any other condition that's caused by a single gene is PGT-M. The M stands for monogenic, which is another word for a single gene condition. So PGT-M and an IVF. And the purpose of this testing is to create those embryos through IVF, test them through PGT, and then select unaffected or negative embryos for transfer into the uterus and essentially reduce the chance of a pregnancy having inherited either NF1 or NF2, depending on which is being tested for. So I'm going to start by giving just a general overview of the process. There's a lot of steps to it, so we'll go through each of these steps in more detail. But just to start off and give you the big picture, the very first step of going through this procedure is developing a custom test, and sometimes that's referred to as the PGT probe. So this is something that's needed by every single couple or every individual that's going to be going through this process, and that makes it very different from a lot of other types of genetic testing. Even if someone's sibling has previously done IVF and PGT, they're still going to need their own custom probe, and I'll explain why that is. And then the next step is actually starting the IVF cycle itself. That starts with a process called ovarian stimulation, trying to get the ovaries to produce as many eggs as possible, and then the egg retrieval, collecting those eggs, fertilizing those eggs with sperm, growing the resulting embryos in a laboratory, and when they reach a certain stage, doing what's called an embryo biopsy, removing a few cells from the outer layer of the embryo and freezing the embryo itself. Those cells get sent off to a laboratory for genetic testing, and then once we get the results, we can plan for the thaw of that frozen embryo and transfer into the uterus with, again, the hopes that a pregnancy will happen. So before all of this can happen, the very first thing that's needed is to determine if PGT-M is going to be possible. So it's only possible if we know the specific underlying genetic variants in either the NF1 or the NF2 gene, whichever gene that we want to be testing for. We need to know specifically what that variant or the alteration in the genetic code is. So that entails first doing genetic testing on the person who has NF. And that can usually take a couple of months, especially if someone is the first person in their family to be tested, because then it involves looking through the entire gene. If somebody already has a relative who's had their genetic variant identified, then it can be a lot quicker because then only that variant needs to be tested for. Usually this is done through a blood sample, sometimes a saliva sample, sometimes a semen sample for a male is needed as well. And about 95% of the time, that genetic variant can be found, and that's usually the case for both NF1 or NF2. About 5% of the time, genetic test results come back negative, meaning that not that the person doesn't have NF, not that their diagnosis is incorrect, but just that we can't find that underlying genetic cause. And in that's a situation where PGT wouldn't be possible. We need to know the exact change in the genetic code to be able to test embryos for it. So the reason that PGT is so much more complicated than other types of genetic testing and why it requires this custom genetic test is because of the small amount of DNA available in an embryo. So that's something that's very different from if we're testing a blood sample or a saliva sample, there's hundreds or thousands of cells that can be tested. But from an embryo, we only get a few cells. So it's a really small amount of DNA, and using those same technologies that we would use on a blood sample or a saliva sample just aren't going to work. So that's why every person needs their own custom test. And what that often involves can be other family members undergoing genetic testing. This is usually the first surprising part of it for a lot of people entering into this process, to know that it might involve other relatives. And those relatives often need to provide not only their genetic test reports if they've had genetic testing, but sometimes additional DNA samples, usually cheek swabs. And the laboratory is going to be using all of those samples to identify what I refer to as unique genetic fingerprints. They're essentially finding genetic markers that are associated with the positive or affected copy of the gene, and genetic markers that are associated with the negative or unaffected copy of the gene. And the way they typically find those genetic markers is by comparing different family members whose genetic status is known. So because of all of this, there are some cases that could be more difficult, such as a situation where someone is the only person in their family with NF. That person has a de novo variant. They didn't inherit it from one of their parents, but it happened spontaneously. That can pose some challenges because there's no comparison available of those genetic markers. Or a similar situation where maybe the genetic variant is inherited, so other relatives do have NF, but they're not available to provide DNA samples. That kind of is the same situation as the first case. Or if someone themselves is mosaic for NF, Dr. Yohei talked a little bit about mosaicism, where some cells have the variant and other cells don't. So it's not to say that PGT is not possible in these three scenarios, but those are some scenarios where it may be more difficult. It may depend on the specific type of genetic variant, and there are some circumstances where even though the genetic variant is found, PGT is still not possible because of one of these situations. So before someone can go through an IVF and PGT cycle, there is some preparation that's needed on both ends, on both the IVF end and the PGT end. And a lot of this can be done simultaneously, but there's sort of two tracks happening. And usually this takes, at an absolute minimum, I would say about 3 to 4 months to prepare before an IVF cycle can actually be started. That's assuming, let's say, that someone has come into the clinic and has already had their genetic variant identified. Everyone in the family who needs to be tested has already been tested. This is sort of a minimum time point, but in reality, a lot of people come into the clinic ready to do IVF and haven't had that genetic testing, and so that can certainly add a few months to that process. So the first step on the IVF track is the initial consultation with the reproductive endocrinologist, or the REI. It's a fancy term for an IVF doctor. And then the IVF doctor is going to order a bunch of different fertility tests. And this is the case whether someone has never had their fertility assessed before, there's no identified fertility issues because maybe they've never tried to get pregnant, or even if someone clearly doesn't have infertility, they might have a child already. But that fertility testing is still really important to make sure that there aren't any unidentified issues. Some people have no trouble getting pregnant on their own, but may not be a great candidate for IVF. And other genetic screening might be ordered at that point as well to see if there's any other conditions to potentially be concerned about. On the PGTN, there's the review of the case, so that's submitting all the reports to a specialized lab. So PGT labs are specialized genetics lab that specialize in testing very small amounts of DNA, and there's only about 5 to 10 of these types of labs in the US. So they review those reports, they determine exactly what they need, and they do an initial consult with the patient. And then they move forward with that custom test development. Requesting any reports, any samples that are needed, and then they perform that probe development or the fingerprint identification. The IVF cycle itself typically can only start once all of that is ready. And that starts with ovarian stimulation. The reason that's needed is because in a natural cycle, only one ovarian follicle is going to mature and release an egg, typically, sometimes two. But it's not very efficient if we're going to be testing and selecting embryos. And so in IVF, we use a procedure called controlled ovarian hyperstimulation. And that's to try to get as many egg-containing follicles as possible. So this picture here is an ultrasound of the ovary, and all of those things that look like bubbles are follicles, and we hope that each one contains an egg. Some don't, but there's a general 1-to-1 ratio, so it gives us an idea of how many eggs there might be. And that stimulation is accomplished through hormone injections, hormones called gonadotropins. They're used to stimulate the ovaries. So usually these are injections that the woman is giving herself. Sometimes her partner may be giving them to her. Occasionally, some people may be really uncomfortable with this process and may hire a nurse to help with these injections. And the injections are typically taken for somewhere between about 9 to 13 days. That's sort of a ballpark. Sometimes it can actually be quite a bit longer than that, but typically not more than a little over 2 weeks. And during that time, the woman is coming into the IVF clinic. This is the point where she's going to be most involved with the clinic, coming in every few days for monitoring to make sure that she's not over-responding or under-responding to those medications. The dosages may need to be tweaked. And so that's monitored through blood tests and sometimes vaginal ultrasounds at the clinic every few days. Once the follicles look like they're ready, they're a certain size, the egg retrieval is the next step. So this is the part of the process that involves a surgical procedure. It's an outpatient procedure. The person would go home the same day. The whole thing usually takes about 10 minutes. She might be at the IVF clinic maybe for a few hours, but most of that is preparation and recovery. This is done under sedation, and it's done using an instrument. I don't know if you can, if the mouse shows here. No, it doesn't. So on the right side, you can see the picture of the cervix and the uterus, and the ovaries are the gray parts on the side, and it's using a tool that goes through the vagina and through the vaginal wall. There's a thin needle, and it basically sucks up the fluid in each of those follicles, and then those follicles are drained out into a little dish that's handed off to an embryologist, and the embryologist looks through the fluid and picks out all of the eggs. Those eggs are then assessed for maturity. And at the same time that the egg retrieval is happening, the male is usually producing a semen sample, or he's produced it ahead of time and it's been frozen and now it's going to be thawed. But that semen sample is then looked through to find individual sperm cells that are going to be injected directly into each mature egg through a procedure called ICSI, intracytoplasmic sperm injection. And there's another method of fertilization as well, but we always use this method whenever PGTM is being done. It just minimizes the chance of contamination. It makes sure that only one sperm has ever come into contact with that egg, and makes sure that the genetic testing is going to be as accurate as possible. So the resulting embryos are then starting to grow and develop in the lab. So we call the day of the egg retrieval in ICSI day 0. By day 1, the embryologist will assess to see if fertilization successfully happened, and that will be a 1-celled embryo. It'll go from 1 cell, it'll divide into 2 cells to 4 cells, and so on. Until about day 5 or 6, a good embryo will have reached the stage called the blastocyst stage. So this is an advanced embryo, and there's some cells around the outer layer, and there's a clump of cells in the middle. And that's the stage where we can remove some cells for genetic testing. So a few cells would be removed from the outer layer, about 4 to 8 cells, and that outer layer of cells is called the trophectoderm, or it's sometimes abbreviated as TE. And those are the cells that eventually would become the placenta in a future pregnancy. And the embryo can tolerate to lose a few of those cells, so that's not a problem. The inner cells, that they would become the fetus during a pregnancy, and those cells we don't actually have access to, and so those cells are not touched. The embryos themselves are immediately frozen after biopsy, and those cells that are taken are put into a little tube. The tube of cells gets sent off to the PGT lab for testing, and remember, they've already developed a custom test to be able to run the analysis. But testing for NF may not be the entire picture. The other thing that we think about with embryos is chromosomal abnormalities. So the chromosomes are the bigger packaging of all of the genetic information. We've got 23 pairs of chromosomes, and they contain all of our 20,000 or so genes. And random chromosomal abnormalities, meaning extra or missing chromosomes, happen very, very commonly in embryos, a lot more commonly than a lot of people think. To the point where about half of all embryos created in the world probably have an abnormal number of chromosomes, and these are just happening spontaneously. They're not typically inherited from a parent. They're just randomly happening when the cell misdivides. And this is a graph showing that the percent of abnormal chromosomes, or the percent of embryos with abnormal chromosomes, increases as a woman gets older. But even a woman in her 20s or early 30s can have about 30 to 40% of embryos with these random chromosomal abnormalities. That's not unusual. And then women in their 40s could have as many as 70, 80, 90% of embryos being abnormal. And because most of these embryos with these abnormalities aren't viable, they either don't result in a pregnancy or miscarry, it's very common to also test embryos at the same time for these chromosomes while also testing for NF or another condition. And we called the testing for NF PGT-M, M being for monogenic or single gene. We call this chromosomal part PGT-A. The A stands for aneuploidy, which is a word that means abnormal number of chromosomes. And really the purpose of this is because we don't just want to find an embryo that's negative for NF, but we want to find an embryo that is negative for NF and has the potential to create a baby. So about 2 to 3 weeks later, we would get the results, and typically we get those results at the same time, both the PGT-M, the NF results, and the PGT-A, the aneuploidy results. And with the PGT-M results, the NF testing, each embryo has a 50% chance to be positive and a 50% chance to be negative for NF. The chance of normal chromosomes is going to depend on a woman's age. So this is a sampling of what results might look like. We can see in the second column there's the NF results, positive or negative, and in the column to the right there's the chromosome results, normal or abnormal. And when we cross-reference them in this case, we get one embryo that is negative for NF and has normal chromosomes. And you might be wondering why on the very left side there's the embryo numbers don't go sequentially. We don't see 1, 2, 3, 4, 5. We see 1, 3, 4, 8, 11. And the reason for that is because not all eggs that were retrieved are going to make it to the point of testing. And that's one of the reasons why we try to get as many eggs as possible, why we do that ovarian hyperstimulation. Most people are not out there, trying to have 20 or 25 kids, but we want to get a lot of eggs like that because we know that the vast majority of them aren't going to make it all the way through. There is this natural drop-off where not all eggs are going to be mature, not all mature eggs are going to fertilize, not all fertilized eggs are going to develop into advanced stage embryos where they can be tested, and then we rule out a lot of embryos based on the genetic testing results and the chromosomal results. So it could take a lot sometimes of eggs just to get to one usable embryo. And everybody's different, every cycle is different. There's some cycles that can produce multiple usable embryos and other cycles that aren't going to produce any. And so it is possible that it could take multiple IVF cycles to achieve one pregnancy. So in terms of the accuracy of these results, The accuracy can depend from case to case. It can even depend from embryo to embryo. But usually it ranges from about 97 to 99%. So that's pretty high, but it's not perfect. And so we think of PGT as a tool to reduce the chance of passing on a condition, but it's not going to completely eliminate it. And it is recommended for that reason to confirm the results that were found on the embryos by one of the following. Either prenatal testing, if somebody wants to know during pregnancy to get that certainty. Prenatal testing can be done starting at 10 weeks. Or if someone just wants to know after a baby's born, then testing the baby after birth through a blood or a saliva test. So after those results are reported and sorted through and someone has an embryo that they want to transfer, then they would undergo the next type of cycle, which is called the FET, or frozen embryo transfer cycle. Usually that's at least a couple of months after the initial IVF cycle. That gives time for basically for all those processes to happen and to get the results and to make a decision about what to do next. But there's also no rush at this point. Embryos can be frozen essentially forever. And so some people may decide to create their embryos even before they may not necessarily be ready to have a pregnancy, but they want to have embryos banked. Once someone decides to go through the FET cycle, it involves preparing the uterine lining. Sometimes that's done through medications. Sometimes it's just following the natural menstrual cycle. And then on a specific day of the cycle, the embryo is thawed. There's another hurdle, which is that some frozen embryos may not survive being thawed, although that's pretty uncommon. About 98-99% of frozen embryos do survive that process. And then the embryo is transferred into the uterine cavity using a catheter that holds the embryo, and it's put in similar to a pap smear through the cervix and into the uterus, and then the embryo is placed in there. And anesthesia is typically not needed for this embryo transfer. This is a lot less involved. Some people do request anesthesia occasionally, but usually it's relatively simple. And then yet another hurdle is the chance of a baby from one of these embryos that has gone through testing. So not every embryo that is transferred is going to result in a live birth. If the embryo has normal chromosomes, so if it's been through that PGT-A testing, then it's got about a 60% chance. So pretty good odds, but it sometimes can take multiple embryos to result in a baby. And another reason why it sometimes can take multiple IVF cycles. Generally, we think of about every 2 embryos with normal chromosomes is going to result in a baby. So one of the big questions that we always get is financial aspects. This is certainly a big part of it. It can be very, very expensive. The costs can definitely add up. We usually hear about IVF being in the range of about $10,000 to $15,000 per cycle. But there's also a lot of add-ons we have to consider: medications, ICSI, the fertilization process, freezing the embryos, the testing of the embryos. So it can be very costly. However, insurance sometimes does cover some of it. Sometimes it covers all of it. But there are some situations where it may not cover any of it. There is a new New York insurance mandate that's going to be effective January 1st of next year. It's not going to cover, unfortunately, everybody. It mostly benefits people who have private insurance through large employers that are based out of New York. So if someone's company is headquartered in another state, then they wouldn't fall into this insurance mandate. But it is going to provide coverage for a lot of people that weren't previously covered for IVF. There's also a New York State grant that can be available for people who have private insurance that doesn't cover IVF. And many IVF programs do have financing and loan programs. If someone needs to use a third party, such as an egg donor, a sperm donor, or a gestational carrier, a surrogate, that can certainly add quite a bit to the costs as well. So to summarize everything, IVF with PGTM is a way to reduce the chance of having a pregnancy that inherits a particular genetic condition. It's often available for both NF1 and NF2, but there are some cases where it may not be possible. It can require the involvement of other relatives, which is not always a comfortable subject for some people. It's most likely to be successful for women in their 20s or their early to mid 30s. That's not to say that it can't be successful at later ages, but it can sometimes require additional cycles in that case. It can be very expensive, but insurance coverage or other financial assistance can be available sometimes. It's a lot to go through. It can be very physically and emotionally taxing. There's hormones involved, which can make women feel not so great when they're on them. Everybody has a different response to it. For some people, it's not so bad. Other people may have a pretty, may really not feel well for a while. It can be emotionally difficult. There's a lot of waiting involved. Everything kind of moves very slow. It's relying on a woman's cycle. And so sometimes if you miss a cycle, you're waiting another month. So it can be pretty stressful. So it's important to have a good support system going through this process. And the very last thing I wanted to stress is how long it can be. So we generally recommend, whenever it's possible, to contact an IVF department. I put here 6 to 12 months, but honestly, I would say it really leans closer to the 12 months before wanting to become pregnant, just because there are so many steps involved to get to the point of even doing the IVF cycle. Then it could require multiple cycles, and then the transfer happens in a separate cycle. So if we account for all of that, it can sometimes take a year or more. So we just recommend contacting that IVF program much sooner than before wanting to become pregnant. And here's the information for NYU Fertility Center. I'll leave this up for a couple seconds while we get our panelists up here to do the IVF panel. So I'm going to start introducing our panelists as they come up. So first is Melissa Cavalier. She was born with NF1. She and her husband met in August of 2014, and they were married in May of 2019. They love hanging out with their dog Casey and watching sci-fi movies together. Melissa and James are now looking to extend their Star Wars loving crew by starting a family. They're currently undergoing the process of IVF and PGT to avoid passing on the NF1 gene in their offspring. Melissa's had the genetic testing done, and the gene was able to be located after some effort. And since that time, Melissa has gone through the extensive IVF pre-testing. She's worked with the laboratory to develop her probe, and she's gearing up for IVF. And Melissa's happy to share her experience with her NF family. Next, we have Michael Loeb, who grew up in Westchester County and went to college in Washington, D.C. He's a 7th grade science teacher in Throgs Neck in the Bronx, and he sits on the board of the education nonprofit Educators for Excellence. Mike and his wife are hoping to conduct their second IVF cycle soon. Then next we have Hillary Saltzman, who's originally from Livingston, New Jersey, and currently lives on the Upper East Side with her husband Nick and their canine son Saul. Hillary graduated from Cornell University in 2008 and has been working for American Express for the past 9 years. Hillary was diagnosed with NF1 at 10 years old when she was seen by a new pediatrician. And she and her husband have chosen to move forward with IVF to grow their family. And I just have to say she's quite a champ for being here, having been going through the process just as soon as yesterday. Next, we have Nikisha Thomas. Nikki's 36 years old and married Jude in 2009 after he was officially diagnosed with NF2 late in 2008. Even though they dated for almost 10 years, they decided to wait and get as much information on NF2 as possible before having children. And after undergoing genetic testing and genetic counseling and developing a PGT probe, they found a great IVF doctor. 2 embryo transfers later, they have an energetic, smart, and occasionally shy little boy, Ethan, who's now 4 going on 54. All right, so thank you so much to our panelists for being here. I'm just going to start by asking, and we'll start, sorry. So I'm just going to start, and we'll go in order, I think, have Melissa answer first. Was choosing IVF a difficult decision, or did you know very quickly that it was the right option for you?
I knew very quickly that it was the right option for me. I actually came to one of these forums, I think maybe about 4 years ago, and it was discussed at the forum, and that's when I got the idea, and after that it was it was my plan from that moment until I would be ready. So, I mean, there are family members and other people who become a little judgmental because it involves potentially discarding embryos that would otherwise be viable but have NF. But, I mean, that's a choice that you make, so.
Yeah, you want to pass it?
Yeah, for me, I felt the same way as Melissa. My NF presents as more mild than it does in some people, and it was communicated to me early on. I've worked with Dr. Yohei, or worked is the wrong term, but he's been my doctor now for many years, and he and other NF doctors I've had have communicated to me that there's little to no correlation between how severe it presents in one parent and then the offspring afterward, and so that was very eye-opening for me. And as I learned that there would be, at least at the time, a percent chance as high as 50%, although it seems much less now, that I would pass it off to an offspring, IVF seemed like a real viable option for me early on too.
And similarly, I think as I got more information, it became very clear that this was the path that we'd want to follow. So I think at the point where I got engaged, I had the first genetic testing done out of Dr. Yohai's office that confirmed that they were able to find the gene. And similarly, while I have a very mild case, I was informed that that would not in any way cause my offspring to have a similar mild case. And so IVF seemed like the best possible choice at the time.
Well, initially we had no clue. So going through everything after he was diagnosed, my husband is the one that has NF2. He said, maybe we should look into this. And I said, we're just going to do this the old natural way. Hello, it's more fun. But after speaking to him and speaking to all the doctors, you realize that, this can be passed on because it is genetically linked. And then they said, hey, IVF. And we said, okay, we'll do it. Try it. Good.
Okay, thank you. The next question, what were you most concerned with going into this process?
I was most concerned with locating the gene. When I started the process, I went to a genetics lab out on Long Island because I live in Queens and it was more convenient for me with work. That turned out to be a mistake because the test failed and they didn't know about the Alabama lab that knows much more about NF. So I went to Dr. Pappas here at NYU, and he sent my test over to the Alabama lab, and then they located the gene. So it made it possible at that point.
I think my answer is similar to Melissa. I think it was about 5 years ago, we also used the University of Alabama, Birmingham to test my blood and to identify the mutation in my gene. Again, at that time, when I first thought about being a parent one day and learning that likely 50% of my children would have NF, again, no correlation between the severity in me and then also my children. Having that test and really hoping and praying that the mutation would be identified, and it was, so that was very, joyous and exciting for me. But also, it was communicated to me by Dr. Yohei and some previous NF doctors that because it is more mild in my case, that I present as a more mild neurofibromatosis person, it may be harder to find that mutation in my DNA. And so that's an interesting catch-22, but I felt incredibly happy and lucky. I say all the time, I'm unlucky, but also lucky at the same time, and I think this is a good example of that.
Totally, it's very similar situation. So to the first question of, did you know that this was the path that you wanted to go towards, there was also the reality of realizing that it might not be a path that my husband and I could explore. And so, again, the first step was getting the genetic testing as early as I think it was recommended at the point where we had gotten engaged, that confirmed that they were able to identify the mutation. And then, so we're using, where I have had the opportunity to meet Andrea, NYU as fertility center. And so once they then identified the right lab to create the probe that was mentioned earlier, the next step was, would they be able to create the probe to ultimately test the embryos for the mutation that I had? And so that was a very concerning time of, I think they had initially, I'd said something like they were 50% sure that they would be able to create the probe, of which Andrea told me she was sure that they would. That was probably them being very conservative, but it was a trying time when we were thinking, what is our other option? Because we had heard that this lab that we were using was like would be the last resort. Like if anyone could do it, they could. And so struggling with the reality of what would we do if, in fact, IVF was not a path that we could go down. Thank God it was, and they were able to create the probe, but I would say that was the most concerning time for us.
For me, it was more about finances. Would insurance cover this? How much of it would be covered through insurance? And that was an arduous thing to go through because the doctor's office would tell you, okay, this might be covered, but then you speak to the insurance company and they said, no, this is not covered. So now you're thinking, okay, how am I financing the situation? Do I even want to go along with this anymore? So for us, it was more insurance and finances as to figuring out how are we going to do this? How are we going to financially get to this point?
And Nikki, while you still have the mic, I'll ask the next question, which was, what was the biggest challenge in the process? Was it for you insurance, or did you find that there were other challenges along the way?
I would say insurance was still, a thing, but it was also the emotional everything you go through. It's a very long process, a very lengthy process, and you learn to lean on each other a lot more because you're going through all of these processes together. And it's emotionally daunting. It takes a toll on you physically, mentally, financially, because it's just a process and you don't know what the outcome is going to be.
Yeah, I think it definitely, dealing with the insurance companies has been a challenge. I think for me, it just challenging was also just understanding how the whole process would work. It felt like information overload. And I have leaned on many folks to just educate myself on what it would look like. Watching, as you explained, the process, and now it's like second nature. I understand, of course, that happens, and then that happens. But in the beginning, I'm like, what's a probe, and how is what I'm going to be going through different from what someone who is having a fertility struggle, how is it different from what they would be going through? This was all information things that I didn't understand. And so not only dealing with how much is this going to cost, but what is the process? And I think what I ultimately learned to do is, one thing that I totally trusted from day one was that I was in the best possible hands. And I trusted the doctors and nurses and everyone and genetic counselors that were giving me advice and driving me along. And I kind of we decided that we'll take it step by step and figure out what do we have to do to get to the next step, and not worry about what's to come, because it gets very daunting. It's a lot.
I agree with what Hillary and Nikki have said. For me, I think it's also maybe not the elephant in the room, but I want to say what's important is I'm a man, and I find this whole process to be incredibly difficult on the women in the room and the women up here, and they'll speak for themselves. But I'm the one with NF, not my wife, and I feel a sense of guilt, but also a sense of pride because she is incredibly strong, and I feel that all women show that again and again. And so that's just something that keeps me thinking about how fortunate I am to have a partner, my wife, Heather, who is just so willing and open and tough and strong and to deal with this. And so as the man, it's just, I feel just along with that guilt, I can't do much about it other than be the best partner I can be. I'll also say, Andrea mentioned that this can be a long process. It's been a very long process for my wife and myself. Over 2 years, we've been at this, and we've been taking our time, but at the same time, as I mentioned, it is presented in myself, NF has very mildly, and there's been a lot of back and forth with University of Alabama, Birmingham, RGI, the lab we've used, NYU, and we're very grateful for all that and that information, hunt that we've been on to figure out what is this mutation, what does the embryo statistics look like for us, and so it's taken a lot of patience which, yes, emotionally has been difficult too.
I would actually agree with that as well. I am the one with the NF, but I do feel very guilty because my partner doesn't have it, and he's, for lack of better words, dragged through this process with me as a result of what I was born with. But the good news, the unexpected thing for me was that I learned you can also learn about whether or not there would be Down syndrome or something of that nature. So at least this is a positive in that way as well. We get to tell whether or not the embryo would likely have that issue as well. So it's helpful in that way. But also the insurance has been a challenge. You just have to keep at it and be an advocate. And don't take no for an answer. Just keep going. And that's it.
So the last question, just in 1 or 2 sentences, because we got to wrap things up, but would you do this all over again? For those of you who have been through the process and those of you who are just kind of starting, do you feel like you went down the right path?
I would say I definitely went down the right path. I've learned a lot. I'm much more informed than before, and I'm hopeful that it'll be a positive result.
I would again too, yes.
Yeah, and I think totally, and I am definitely mid-process, but one thing that I think became very clear to me in terms of knowing that this was the path that made the most sense for us was at those inflection points where it was made clear that this might not be an option, and how much I hoped that it would be, has given me strength going through like some of the more challenging times, that I feel lucky that this is an option for us and would certainly do it again.
Hell yeah. He told me the other day, I need you to make me another person. So we're going to try to make him another person.
Thank you guys so much for being so honest and open with us. We really appreciate it.
Is it working? Yeah, it's working. So the first condition would be, I'm going to work from the outside in. So the first thing that we're looking at are eyelid abnormalities. So patients with neurofibromatosis type 2 can have plexiform neurofibromas involving the eyelid, and then levator muscle dysfunction. And the levator muscle is the muscle that allows us to open our eyelid. And so you can imagine if that muscle is not working, the eyelid's not going to stay open. And why this is very important, especially in children, is when we're young, our eye-brain connections are still developing. And an eye that can't see well, those connections don't develop well. And ultimately, that can lead to a condition called amblyopia, which is a permanent loss of vision. So if we don't help children see better from obstruction such as the eyelid, they may never get good vision in that eye. This is why it's so important to recognize this condition very early. And so, one, if the eyelid is drooping or not closing completely, you're going to develop amblyopia, which is that permanent loss of vision. And 2, patients can develop dry eye, and that's because a portion of the eyelid remains open, and when that happens, the eye dries out. We all hear about dry eye, it's very commonplace, but when it's due to the eyelid not functioning well, it can actually cause severe eye disease and possible vision loss. And so there are a number of ways that we try to treat this. Here you can see that there's a plexiform neurofibroma involving the upper eyelid, and that can cause a deformity of the eyelid. And then you can see a patient who, when the eyelid is completely closed, this patient, if this was a young child, would not develop vision in that eye. So what do we do for when there's disfigurement of the eyelids and when the eyelids don't close completely and patients develop dry eye? So we often advocate for lubricating drops or artificial tears. These are medications you can buy over the counter. There are various different kinds, and that can get confusing, and your eye doctor can recommend to you which ones are best, but we often recommend a preservative-free lubricating eye drop, and this can be used as many times during the day as you want without causing any harm. The other thing we recommend is lubricating gel or ointment before bedtime. When you're asleep, your eye doesn't blink at all, and so you're not going to be waking up every few hours to put drops in. If you use an ointment before bedtime, that can allow the eye to stay lubricated. A very important thing to remember with this, though, is that ointment can cause blurred vision, and if you're at risk of falling at night, this can only compound the problems that you can have. And so sometimes I recommend to patients to alternate between the eyes. put lubricating ointment in one eye one night and the other eye the following night. That way you at least have vision in one eye to prevent from falling in the middle of the night when you get up to use the bathroom or for any other reason. The other thing that we can use are called punctal plugs. If you've ever seen along your lower eyelid, we have little holes in the bottom, and those are the punctum through which the tears drain. We can put a little plug in there to prevent outflow of the tears, and that allows the tears to sit on the surface of the eye longer and to help lubricate eyes better throughout the day for patients who have dry eye. And the last thing would be something called a type of surgery where we can implant a gold weight into the upper eyelid. Putting a weight in the upper eyelid allows it to droop a little bit more and then cover the full area of the eye to prevent dry eye. This would not be ideal in a child, for example, a very young child, because we need them to be able to see. The next thing that we can see in neurofibromatosis is something called strabismus. Strabismus is when the eye muscles don't function well, and so patients' eyes are not aligned perfectly straight. A lot of people might hear the term, I have a lazy eye or I'm cross-eyed, and this is the medical term for that. So this can happen for a number of conditions. One, the eye muscles themselves don't function well, and so an eye does not see well and starts to turn in or out. Or there is a compressive tumor, and that's affecting the nerves that go to that specific muscle, and that muscle doesn't work well, and then the eyes turn in or out, up or down. This can be one of the first signs of neurofibromatosis too in certain patients. And so recognizing this and going to see your eye doctor and them looking for a cause for this condition can ultimately sometimes lead to this diagnosis. Another condition is a cataract. When we are born, we have a lens in our eye and it's generally clear. Sometimes babies can be born with lenses that are not clear. They either have a white opacity or yellow opacity in them. This goes along the lines of something we talked about before. If an eye cannot see well, the eye-brain connections don't develop well, and ultimately, that patient will not develop good vision. It's important to catch this early because it is a treatable condition of permanent vision loss. So if you have a young child, 1-2 years old, who has an eye exam and a cataract is found, we then try to determine, is that cataract important and impacting the patient's vision or is it not? And if it is, we try our hardest to remove that cataract as soon as possible to allow that child to develop good vision in that eye. This is something that can go easily unnoticed in children. And so if a diagnosis of neurofibromatosis is made, the child should go to see the eye doctor as soon as possible following that diagnosis. Since about 30% of patients with NF2 develop cataracts. That's a very large number. That's 1 in 3 patients, and that's a lot of preventable vision loss. So it's very important that once a patient has a diagnosis and a person has a diagnosis of neurofibromatosis type 2, they come to see an eye doctor right away. The next thing is something I see quite often, and it's called an epiretinal membrane. You can see the picture on your right-hand side is what a normal retina would look like. There's a very nice smooth surface and there's a dip in the center, and that is where our finest vision comes from. Now, if you look at the picture on your left-hand side, you can see that there are dips and there's valleys and elevations on the retina, and it's not as smooth as the picture that you see on the right. That's an epiretinal membrane in a patient with neurofibromatosis. This patient is lucky enough to probably be able to see very well because they still have that central dip, but this is a very subtle sign and can go missed in many exams. We can also see something called a combined hamartoma of the retina and RPE, and this is a congenital lesion, which is something that you are born with. Fortunately, it is not a malignant lesion or a cancerous lesion that can lead that requires it to be removed, but it can lead to a permanent loss of vision over time, and it can progress. If you look at this picture here, these are retina photographs. In the first one, on the left-hand side, it's maybe difficult to appreciate in this light, but there's a color, it's grayish brown, and it's elevated. It's a pretty large area on the retina. Fortunately for this patient, that lesion is outside of the center of their vision, so they may never notice it and never have any problems from it. On the right-hand side, you see 2 images. The top one is a color picture of what we call a hamartoma. And the bottom one is a cross-section through it. That's a similar image to the one I showed you earlier. And this image, the way we interpret it and think about it is, if you have a sandwich and you cut it in half, you can see all the layers in your sandwich. You can see the bread, the turkey, the lettuce, the tomatoes, everything. And you can see if something is missing or if something's not, if something is there and is not supposed to be there. And so in this image on the bottom, this gray and white lesion image, you can see that there is disruption. It looks very different from the image I showed you earlier. And from this, we can see that this patient who has this lesion in their eye is actually having disruption of their vision. This might be someone that we would operate on to help save their vision, especially if we saw that there was progression throughout their life. Finally, then, there's something called a retinal hamartoma. It is a dysfunction of the retina because of an abnormality of its growth. And so this is a young child who came to me. The picture on the left-hand side is his right eye, and the picture on the right-hand side is his left eye. Unfortunately for this patient, the lesion cannot be removed, and there's nothing we can do for the lesion itself. But what is important to recognize here is this patient has one good eye and one bad eye. So the best thing I can do for this patient is to recommend that this patient wear glasses for the rest of his or her life. And that's important because now this patient is only walking around with one good eye. God forbid he were to get into a car accident and glass shattered into that good eye, or he was walking down the street and someone threw a baseball and it hit him in his good eye. And so it's very important to emphasize to these patients and to their parents that we want them to be wearing glasses, even though if they feel they can see well out of their good eye. So what are our recommendations for patients with a diagnosis of neurofibromatosis type 2? We recommend that upon diagnosis, they have a complete eye exam and that they have at least an exam once a year. There are certain patients, especially children, that I prefer to examine 2 to 3 times a year to see if there are any other conditions that pop up and that we need to address sooner, especially because children cannot tell us what they can and cannot see because they don't know how they are supposed to be seeing. And so it's very important that we work to catch these eye problems before so that everyone can have the best quality of life. Does anyone have any questions? Yeah.
What, if any, role would Botox help or not help in the, I guess, where the eye is not closing entirely and there's a lot of that tearing going on?
So Botox has a really good role in that. The oculoplastic surgeons use Botox to drop the eyelid, but if the eyelid still doesn't function well because the muscles don't function well, you will still have a little bit open, and so that's where you want to use eye drops and ointment. But Botox can work very well for muscle dysfunction.
Okay, then in the same vein, is there an adverse reaction as to where the Botox is then put in one eye? What does it hinder the other eye, kind of?
So not generally, no. When Botox is, unfortunately, it's not a very exact procedure, and so you may involve other nerves with your injection, but it's a very safe procedure and it often works really well. It very rarely will affect the other eye and the drooping of the eyelid in the other eye because the muscles and nerves being targeted are specifically on the side that you're injecting.
At what point do you say then that the weighted eye weight would be the better option, dare I say, to something as like compared to Botox?
So this requires, multiple types of examination, but it ultimately comes down to what is causing the problem. Is there a nerve that is not functioning well? And so you can't use something like Botox, or is it the muscle that's there or not there? And if the muscle is not there or not working well, then the gold weight is preferred.
Okay. All right. Thank you.
You're welcome.
So I'm happy to speak for a few minutes about some updates in terms of clinical trials that we're doing in NF2. So this is a picture that you're very familiar with. This shows the vestibular schwannoma, which is one of the main problems in NF2, and I'll tell you a little bit of how we have run clinical trials to address this problem. A second problem, a major problem in NF2, of course, are the meningiomas, which, as you can see here in these cartoons, can occur anywhere in and around the brain and cause problems. Just to tell you a little bit about what really are the goals of clinical trials, of course, in general, the goal of clinical trials is to make patients better or find things that can make patients better. But what are the specific goals that we're defining for clinical trials for NF2? So one are functional endpoints, and in NF2 that is primarily the hearing, so either improvement of hearing or at least prevention of worsening hearing. And then we have imaging endpoints. That's when patients get MRIs. So we're not looking at a function per se, but we're looking at an image. And specifically what we're looking for is the tumor size, because we think that if a tumor gets smaller or stops growing, that would hopefully then also translate into functional improvement. Many of you are familiar with bevacizumab or Avastin. And you can see here a treatment result of using bevacizumab in an NF2 patient. So the arrow points to a large vestibular schwannoma that is compressing the brainstem. And this patient only had surgery at this point on the left side where you don't see a tumor. There was a tumor previously. And at that point, the patient had no useful hearing in either ear. And you can see after treatment with bevacizumab, so that's about 6 to 12 months difference, you can see the tumor got a lot smaller, but as importantly, the hearing improved, and you heard earlier from Dr. Friedman about the word recognition score. In this patient, he was actually one of the very best responders that we've ever seen, and the word recognition score went from 0% all the way to 100%. Now, that doesn't happen in all patients, but a significant improvement in the word recognition score can happen with Avastin. We ran a clinical trial, and I'll get back to Avastin in a minute. We ran a clinical trial with another drug called lapatinib that was taken by mouth. We observed tumor shrinkage in about 24% of patients, but hearing improvement was rare. We only saw some hearing improvement in 1 out of 13 patients. We then did a second study with everolimus. It's called also Afinitor, and you just heard about a little bit on the prior presentation. And that was done by 2 groups. It was done by us at NYU and also by Dr. Calamarides' group in France. And we did not observe any tumor shrinkage, and the Paris group did not observe tumor shrinkage either. But in some patients, slowing of tumor growth was noted comparing to pre-treatment in the Paris study. We didn't see that in our study. One of the reasons may have been that our study was smaller than the Paris study. So perhaps everolimus has a role in slowing down tumors in some patients, but we probably need to do more studies to be able to say that with certainty. And then we more recently ran another clinical trial at NYU primarily with a drug that has some similarities to Avastin, but it's taken as a pill. And the results of that are pending, and we hope to be able to summarize them and publish them over the next year. At the present time, bevacizumab remains what appears to be the most active drug for NF2 patients with vestibular schwannomas. It does not appear to help meningiomas, but it does seem to be very effective for many patients with NF2 in terms of vestibular schwannomas. The first prospective clinical trial was done at Johns Hopkins and Mass General Hospital in Boston. You can see here what the key data are from this study. The Avastin was used every 3 weeks, not every 2 weeks, at the dose you see there. And 43% of NF2 patients experienced some tumor shrinkage with this treatment. And sustained hearing improvement was seen in 36% of patients. So we tell our patients that, based on this data, about, up to half of NF2 patients can experience tumor shrinkage, and about 1/3 of patients can expect to see some hearing improvement. As you can imagine, the chance for hearing improvement is dependent on a lot of factors, including prior surgeries, other treatments that have been done previously, such as radiation, and so on. Then we conducted a clinical trial in the NF Clinical Trials Consortium that you've heard about. So this is a group of many centers working together, and there was a larger study. The dose was increased at the beginning of the treatment, and the idea was to find out whether increase in dose might lead to better results. And this did not seem to turn out to be the case. We saw tumor shrinkage again in about, close to 50% of patients, specifically the adults. Well, the new observation was that we actually did not see tumor shrinkage in children. This was a first study that included a significant number of younger children as well, suggesting that Avastin is not as effective in young children. Hearing improvement we saw in this study in 53% of adults and 14% of children. So again, it does not seem to be as effective in children in terms of improving hearing or shrinking tumors. However, importantly, there was some improvement in tinnitus or ringing in the ear in the majority of patients. And some, but not all patients tolerated the dose reduction that was done after the first 24 weeks. And some of those patients had to be dose re-escalated to the higher dose. So we're still learning, and this is one of the ways we're learning how to optimize the amount of Avastin that we have to give to each patient, because the less Avastin we need to use, the better in terms of long-term side effects. So to summarize the conclusions from those clinical trials with Avastin or bevacizumab is that vestibular schwannomas respond, but not meningiomas. Side effects that include high blood pressure and proteinuria, which is protein in the urine, is commonly seen in patients, and usually those take a while to develop, months or sometimes years. Severe side effects are extremely rare, so that was another important piece of information from these studies. And with few exceptions, the high dose generally was no better than the standard dose of Avastin. Tumor shrinkage is common in adults and rare in children, but tumors stop growing in the majority of all patients while they're on Avastin, including children. Hearing improvement can be seen in subsets of children and more commonly adults. And the dose can be safely reduced in some patients, and we're still learning which patients these are. And we're learning that individualized dosing based on MRI results and hearing tests can help us find the optimal dose for each NF2 patients. And there seem to be significant differences in what that optimal dose is. So you heard just in the prior presentations about some new approaches. There are new laboratory tools, genetic tools that have evolved over the last few years. There are new and better mouse models to study NF2 in the laboratory. And there are new initiatives. And you just heard about a wonderful new initiative to accelerate research in NF2. And the other one that I'm showing here is the CTF-led so-called Synodos initiative to find new therapies for NF2. And all of these are very important. The NF Clinical Trials Consortium, many of you are familiar with, and there are many or several patients in the room that participated in clinical trials through the NF Consortium, such as the Avastin clinical trial. There's 24 sites across the US. It's sponsored by the Department of Defense. One NF2 clinical trial has been completed, and I showed you the results. And a new clinical trial is currently in preparation using a drug called crizotinib, which is taken by mouth. Crizotinib was shown in the laboratory, and that is the reason we picked this medicine, to slow down NF2 tumor growth in mice. So the control mice, you can see, have larger tumors than the crizotinib-treated mice. And this medicine is currently already FDA approved for lung cancer. It is very safe in adults and children, and generally well tolerated. And you can see some of the most common adverse reaction here, all of which are reversible, and it includes some blurry vision, some GI symptoms, and some fatigue in some patients. The patient eligibility for this clinical trial is that the patients have to be at least 6 years of age, and they must have a progressive or growing vestibular schwannoma that has a certain minimum tumor size so we can measure it accurately on an MRI scan. The treatment is taken by mouth twice daily. MRIs and hearing tests will be done as usual every 3 months. Treatment can be done for up to 1 year, and the anticipated start date is the spring of next year. So we're very excited about having a new clinical trial option for NF2 patients, and we look forward to opening the study at NYU, at Memorial Sloan Kettering, and at the other NF2 consortium sites. This is the end of my talk. I would like to thank everyone for their attention, and I'm happy to answer any questions you may have. Thank you.
Okay, so I'm going to talk a little bit about some of the hearing rehab options that we take advantage of, particularly in patients with NF2, and a little bit about our philosophy of how we approach hearing in this particular disease. And then we'll take any questions, and we'll have a panel that sort of goes into this in a little bit more detail. So I'm an neurotologist, so I work with neurosurgeon to deal with tumors, but part of the reason we're also on the team is our expertise as it relates to the facial nerve function and hearing issues. And a general sort of theme that underlies our treatment for NF2 is that we treat patients and not tumors. So by that I mean that there are patients who require removal of their tumors, but we rarely do this with the goal of improving hearing. And we're willing to watch tumors as long as they're not dangerous, as long as they're not pushing on other structures or causing symptoms, and actually choose to just observe them and focus on what we can do to make the patient's life better. Sometimes that involves hearing rehabilitation, sometimes it just means checking up every few months with repeating MRIs and knowing that we're in a safe situation to continue to watch and maximize the quality of life for the patient. So you might ask, when do I need surgery? And so this is a different question when you're thinking about NF2 patients versus patients who have acoustic neuromas from a sporadic situation not related to a genetic condition. And generally, though, that we're choosing to do surgery when there's issues with compression of the brainstem, for example. And as I said, we often don't make things better in terms of the hearing. We're doing this because it's potentially dangerous to leave alone. There are cases with very small tumors where we can preserve the hearing that you already have if you still have it at the time. And there's also potentially a role, as I said, for non-surgical management, watching the tumors, making sure that they're safe while we continue to extend the time period of which the patient has hearing. And really, this comes down to the uniqueness of the clinical situation, and that defines what options are available to the patient. We see everything from small tumors, much larger tumors, patients who come to us when they already have poor hearing or normal hearing. Obviously, with NF2, unique to that population is the bilateral tumors or tumors on both sides. We see children presenting with acoustic neuromas as young, as their low teenage years, and then obviously adults who don't present till much older. So these are some different possible situations after surgery. We may be able to preserve hearing. We may lose hearing and preserve the nerve. We may lose hearing and there may no longer be a nerve. You may have hearing just on one side or no hearing at all. So these are some different sort of common circumstances that we confront. And to deal with this, there's a bunch of different rehabilitation options. I'm going to just give you an overview of them, but suffice to say that there's always options to help. Some of you are aware of sort of speech reading and lip reading skill, which is a skill that can be learned, and that can help a lot with when there are visual cues to help understand what's going on. There's hearing aids. I'll talk more about those, what we call bone conduction devices, both surgical types and non-surgical types. And then some of the things that require a surgical procedure but can bring back hearing when there's no hearing include cochlear implants and auditory brainstem implants. So you just need to know a little bit about how the ear works to discuss this further. So usually sound comes in. This is vibration, acoustic energy moves the eardrum, moves the bones of hearing. That sends off a fluid wave in the cochlea, and that gets transduced along the nerve of hearing that goes between the inner ear and the brain. So that's sort of hearing in a nutshell. There's two types of hearing loss, and the type of hearing loss we're talking about as it relates to tumors is what we call sensory neural hearing loss, and this is acquired. These are often in patients who have had hearing up until the time where they start to lose it, and we call that acquired sensory neural hearing loss. Many of you are probably very familiar with this kind of test. This is an audiogram or hearing test. We can test the ears individually. The red represents the right, the blue the left. We can grade sort of the severity of the hearing loss based on where they fall on this diagram. And then there's another part of the hearing test that relates to how sort of a functional measure of what you're able to do with that hearing. Patients may or may not have hearing loss, but that can impact disproportionately what we call their speech perception or word understanding. So in addition to sort of where these lines end up, you'll often get a percent score for each ear. And that's really important for understanding the degree of hearing loss and sort of the functional condition of the hearing. I mentioned that there's times when we can save hearing surgically. That's really only for fairly small tumors, and that's not usually the case for NF2 patients. Hearing rehabilitation options this is just an overview, and I'll talk through these a bit, but essentially if there's functional hearing, but it's not quite normal, then we're using conventional hearing aids or amplification to make sound louder. If there's no hearing and no nerve, then we're talking about something that sends the sound over from the non-functional ear to the good ear. Some of those options include bone conduction devices, a cross device. I'll talk about the newer option of a cochlear implant for this population. If there's no hearing, but the nerve is intact connecting the ear with the brain, that may be an option. And then if there's no nerve and no hearing, another surgical option is an auditory brainstem implant. So when is a hearing aid appropriate? This is a patient that has functional hearing, but it's not quite at normal levels. Sound is getting through. So how do you know if you fall into this group? If you can talk to someone in quiet but are having difficulty with things like using the phone, struggling in noisier environments, then it's possible that a hearing aid would be appropriate. This is usually not the case after surgery. After surgery for something like an acoustic neuroma, usually we're talking if there's hearing loss, it's usually not the type that's going to be amenable to a hearing aid. Another device is called a cross-contralateral routing of sound. For this to work, you have to have at least one good ear with good hearing and perhaps no functional hearing on the other ear. Essentially what happens is you wear a microphone on the poorer ear, that's seen here, and then on the opposite ear there's a speaker that communicates wirelessly. This arrow is just showing you sort of what's happening, but in reality most of these devices these days are wireless or Bluetooth, send the sound over to the other ear and allows you to essentially hear from both sides without turning your head. So some of you who have single-sided hearing loss may know that if somebody's standing on your bad side, you sort of have to turn your head to hear them. This sort of helps with that problem. It can help with background noise. It doesn't require any surgery. It essentially looks like you're wearing two hearing aids. And another nice advantage to the cross is you can do something, what's called a bi-cross. You can actually aid the better hearing ear in cases where there's a hearing loss in both ears. And that's unique to this device as compared with what I'll talk about next. So this is just a diagram showing that a cross just sends sound over to the good ear from the non-hearing ear, or a bi-cross, which has also a hearing aid for the better hearing ear. So why might you choose this? As I said, it overcomes the head shadow effect if somebody's standing on your poorer side. It's not exactly like hearing from two ears because you're really just sending the sound to the better ear. And it does have the disadvantage that it's slightly blocking your better ear. Another option which avoids some of these pitfalls is a bone conduction device. You may have heard of this as the Baha, which is just one particular brand. There's also a couple of other brands. Essentially, this conducts the sound from a microphone through a speech processor directly through the skull to vibrate the better inner ear. So you need to have at least one ear that's working well to carry the load. These come now in both surgical and non-surgical options. They can be attached by a headband or an adhesive sticker. So it gives you the option of really trying it before if you're thinking about the surgical one. The surgical option does provide better sound because it's more direct. It's a small, short outpatient surgery, less than 30 minutes. And can work even if there's no nerve on that side. The advantage of this over the cross, which we just talked about, is that you're only wearing something on the one side with the hearing loss. The better ear is not affected. So here's what these look like. There's a titanium implant that may stick out of the skull in one of the forms, and then you wear this external sound processor attached to it. This is sort of a diagrammatic picture of the abutment. This is always there once implanted at the time of the procedure, and then sometime after the procedure it gets loaded with the sound processor, which sends the sound over to the other side. This is another brand, just gives you another idea of what these look like. So this is, like I said, you can test this preoperatively with a headband. It's comfortable, it's pretty straightforward, and gives us a very predictable outcome. Some issues related to this include issues with skin reactions for some patients, and you're not really hearing with both ears. It's sort of sending the sound over to the better side. There's some newer versions of this made by a number of different manufacturers that have the advantage they've overcome this skin issue. So there's nothing sticking out of the skin. There's some sort of magnet that connects the device to the skull. So this is a relatively new issue. It does require a slightly more involved surgery, closer to about an hour. Still outpatient, you still go home the same day. So the next sort of level of options, and this is in cases where there really is not any functional hearing in either ear, is a cochlear implant. So you might be appropriate for a cochlear implant if you know that when you turn up the volume, you still can't understand words. These are patients that may have had prior surgery on an ear. They may have had prior radiation. They may have undergone some medical treatment in terms of some of the drug therapies that we've talked about. They may have a small tumor that's being observed, and there's not really a compelling reason to do surgery, but the patient really wants to be able to hear better. The patient may essentially be deaf in that ear, have no hearing whatsoever. As long as there's still a nerve connecting the ear with the brain, this is potentially an option. I should just mention that in these cases, something that we'll ask about and we talk about is the duration of hearing loss. The longer you've been without hearing, the more limited the outcomes with a cochlear implant, generally speaking. This requires another outpatient procedure, slightly longer, about 60 to 90 minutes. There is an external piece that you wear, so we talk a lot about the implant, but the implant is the internal part put in at the time of surgery. There's also an external part that you have to wear on the outside, and the device only works when you're wearing that external portion. Essentially, we can, in these cases, restore hearing to a non-hearing ear, and in the best of outcomes, patients can actually use the phone with that ear. So here's just a diagram that shows the different parts. During the time of surgery, we're implanting this internal component, and then you wear on the outside a microphone attached to this receiver. They come in different forms, but essentially this captures the sound, sends it to the internal device, and that's connected to this electrode, which is located within the inner ear, within the cochlea. And then you see that at number 4 here labeled as the nerve itself. So you still need to have a nerve connecting the inner ear with the brain for this to work. This is a patient that has one. This is an example of what it looks like on the x-ray. So you can see that coiled part of the electrode inside the inner ear. So in cases after a procedure, let's say, or after radiation, if all hearing is lost, we always ask ourselves, what's the condition of the cochlea? What's the condition of the cochlear nerve? Because as I just said, cochlear implants can work even after drug treatments, or after radiation, or after surgery. Sometimes we'll even consider doing a lesser surgery to try to preserve that nerve to make cochlear implant a reasonable option. If a patient doesn't have that nerve and we cannot consider a cochlear implant, then we might consider an auditory brainstem implant. So these are devices, neither of these technologies are new. The application of cochlear implants to NF2 patients is a newer one. By that I mean the last 10 years or so. ABIs have been around for this population even longer, and an auditory brainstem implant is used when there's no functional hearing in either ear or when that is an expected outcome in the future. So if we're expecting that the patient is going to lose hearing, we might talk about an ABI. You might do it after prior surgery if there's no hearing left, or you might do it at the same time of tumor removal as when tumor removal is planned. It may also be done in patients who have had a cochlear implant and lost benefit from it. If they're looking to have some sound awareness from the environment, perhaps assist with speech reading and essentially improve their quality of life. This might be the only option, and it's often used when patients really have no other access to sound and we're trying to do something to restore that. In general, the results are not as good as with a cochlear implant, but they can still provide significant benefit to patients' quality of life. This shows you that the device itself looks sort of similar in terms of what we call the receiver stimulator or the internal part. The major difference is that this has a paddle that's implanted against the brainstem, against the auditory brainstem. So no nerve, no cochlea. If there is no cochlea whatsoever, or if it's been used as a means of getting towards the tumor, then this is potentially an option. This just shows some intraoperative photos of the implant itself in place in the brainstem. And as I said, this is a sort of complicated process in terms of how these get programmed. It's not quite as straightforward as a cochlear implant, but this paddle can be programmed with the audiologist to try to optimize what sort of sounds we can give the patient through these devices. So just in comparing cochlear implants and auditory brainstem implants, the major differences to be aware of: you need to have a nerve to get a cochlear implant. This is an outpatient surgery, an hour or so, whereas an auditory brainstem implant is a bigger procedure. It's a craniotomy, it's a brain surgery, sometimes done at the same time as tumor removal, and generally outcomes are much better for a cochlear implant when that's an option. Generally for ABIs, we're telling patients about using multimodal communication, planning on using their ABI along with visual cues, maybe learning how to speech read to give them the best possible ability to communicate with others. So this just talks a little bit about what can we expect from an ABI, and these are obviously very different across patients. At the very least, we hope for detection of environmental sounds, detection of when somebody is talking. In better situations, patients might actually be able to perceive what's being said or recognize particular words along with visual cues. And even fewer patients are actually able to recognize speech without visual cues or without lip reading. I'll just mention some resources that when we're not able to help with hearing rehabilitation devices or even in conjunction with them, there's an option for caption devices some of you I'm sure are aware of. Things like that help you feel safer at home when you're alone, bed shakers, phones with flashing lights, transcription services. Auditory rehabilitation can be very helpful in terms of learning skills like speech and lip reading, and then of course manual communication such as ASL, American Sign Language. I'll mention that drug trials have really, as part of our team, have really changed the way we think about NF2. So, used to be with tumors, you see a tumor on a scan and we had thought that, that needs to be operated on. As I mentioned before, that approach has really changed, and our goal often is to prolong the period of natural hearing function or a time until we are forced to intervene. And so sometimes these drugs can help us prolong the benefit that a hearing aid provides or a cochlear implant provides, essentially by delaying tumor progression and delaying the need to do some more definitive surgical procedure. And you've heard about some of these drug trials before. So I'll just wrap up by saying that, as part of a comprehensive NF2 center, we're really emphasizing the treatment of patients and not tumors. And we're looking for things that will improve patients' quality of life. Sometimes that means tumors can be monitored and we don't have to do any intervention for the tumor itself while we focus on how to improve hearing. And these options for hearing may change over time based on individual tumor characteristics and the treatments that the patients have had. So I will stop with that and then invite the panelists up for Dr. Rowland's next session.
Just in the interest of time, you can read the bios on our panelists, and I want to thank the panelists for agreeing to come and tell us a little bit about themselves and some of their hearing rehabilitation choices. So I also want to specifically thank Christine, who just spent the week in the hospital and still, in a heroic fashion, decided to come and join us because she felt it was important. So each of you have something different or made different decisions about hearing health, and so I'm just going to go down the row. Marianne, you were completely deaf for a number of years. And then
yeah, I was
something
deaf
happened.
for 14 years. What?
Go ahead.
Okay, so I was deaf for 14 years, 20 now. And years ago, about 14 years ago, I actually came to see you, Dr. Rowland, about a cochlear. But back then, it really wasn't done with tumors that were growing. And it wasn't until about 6 years ago I actually went with my daughter to see Dr. McMenemy, and he said to me, "Did you ever think about a cochlear implant?" And I said, "Years ago." And he said, "I think you should look into it." And I did. I went to Dr. Shapiro, and they tested my nerve, and it was functioning, and it was done, and it changed my life, and it was the best thing that have happened to me.
And what kind of benefit do you get from your cochlear implant?
Hearing, I mean, everything is just, I can't explain it to you, just the everyday things that people take for granted, that I never heard my children speak. And that came, I was able to hear them speak again. And it's just, I function not hearing. That wasn't the issue. It was a function that just enhanced my life again. And I'm forever grateful to Dr. McMenemy.
So just so the audience knows, and this is something new, we never thought or understood that you could still have a tumor growing on your nerve. And in Marianne's case, she actually had a tumor inside of her cochlea. It had grown inside the cochlea. But if we can get an electrode there and can present that nerve that can still carry some signal to the brain, then we can gain hearing. And we do a test ahead of time called a promontory stimulation test, where we can stimulate the cochlea right in the office with some local anesthesia and determine if a nerve is able to carry some signal. If the patient has auditory perceptions, then we think a cochlear implant might help. So this was sort of new territory when Marianne and Dr. McMenemy decided to do this, and she's getting benefit and her tumors are stable. Christopher, you decided not to have or not to engage in any kind of an auditory prosthesis. Maybe can you tell us a bit about those decisions and how you made them?
Yeah, I mean, some of that is just benign neglect. I think I've felt dealing with other health stuff first, and I've had my right tumor removed and the auditory nerve, that part of it when I was 15, and that was 30 years ago. And then I started then I wore hearing aids for a while in my 20s, and then about 12 years ago, all the hearing was gone, and it's been so long, and I've just gotten so used to it, and the decline was so slow that I just made a lot of adjustments in my life, and I have a full-time job, and I use different aids at work to make that happen. And I mean, some of the advancements I'm hearing about today makes me rethink some things, but in a lot of ways, it's just really worked. We had talked at one point about an ABI, and you mentioned to me it was mostly about background noises and improving that, and I never really felt isolated from the environment in that sense. And we live in New York City, and it's already loud, and so the part of hearing, I want to hear people's voices, not like this, noise of the street. So that was really what guided me.
Okay, and that is an important point, and Dr. Freeman mentioned that prolonged duration of deafness also affects outcome. So if we're going to do auditory prosthesis, I mean, in Marianne's case, we all got very lucky, but if we are going to do an auditory prosthesis, we want to do it as soon as we can after the deafness occurs. And we'll get to another panelist who kind of made that decision as well. But let's move on to Jude. Jude, there was a period of time when we were throwing our hands up in the air. We didn't have drugs. And there was sort of a movement, probably in the 90s, when we were suggesting operating on tumors when they were smaller, not until they became very dangerous and we had to do something. And the idea is maybe we give patients 3 chances at hearing. Maybe if we could take the tumor off the nerve and save the hearing. Maybe if we didn't save the hearing but still had a cochlear nerve, they could get a cochlear implant. And if that didn't work, then we can do an ABI. And I think you were part of that understanding at the time. And we did take a tumor off your nerve, off of you, and you did have a nerve that still functioned, and you opted for a cochlear implant. Can you tell us a little bit about what that was like in that experience?
My experience, this was maybe about 10 years ago. I believe I was about 25, 26 maybe, and Dr. Rowland performed my removal of the acoustic neuroma, and the option of cochlear implant versus ABI, that was the big, conversation, big debate. I opted for the CI when it was mentioned that it probably is my best chance of understanding sound. It wasn't more about not having hearing. It was more about just being able to have some type of daily function where I could understand my family, understand people in the workplace. I also understood, as Dr. Rowland just mentioned, that time is everything, and being able doing the procedure as soon as possible rather than waiting would give me the best benefit. And that's when I select, okay, you know what? I think it was maybe 4 months after my initial surgery, removing the tumor, we decided to go ahead and have the CI done.
Thanks, Jude. Do you still get as much benefit now as you did when you first got the CI?
I believe I probably get even more benefit now than I did in the beginning. Because honestly, the beginning, I'll admit, I didn't wear it as much as I should because I still had some hearing in my right ear. So I didn't wear it as much, which is not a good thing. But definitely without my CI, my 4-year-old could be sitting beside me crying and I would not hear him. The CI, it's definitely been a lifesaver for me. I can understand it as well as lip reading. It's the best combination for me. Like I said, without my cochlea on, I hear nothing. There's a big problem, 5 o'clock in the morning, my alarm is going off. Of course, I'm sleeping. I'm not sleeping with my CI on. I'm not hearing it. So my wife is shaking me to wake up. So thankfully, with the cochlea, it's been a great benefit.
Thanks, Jude. Christine, now you had some big surgeries, and on your second one, you opted to consider what we call a sleeper ABI. In other words, you still have good hearing on one ear, but you got the ABI at the time of tumor removal on the other ear. And you've nicely reminded us that it's not sleeping. You're still using it once in a while. But we call it a sleeper because we get it in there knowing that there's potential for the good ear to go. And since you're in the neighborhood, why not put an ABI in there after tumor removal? And can you tell us a little bit about your experience with that? And I think you use it or play with it more now than you did initially because you had many other things to worry about in your life.
Really, once I started school, I left for college last year, I decided to start using it more, I guess because I was maturing and coming around to it, although I was very stubborn at first and didn't want to use it and didn't want to be reminded of it. But again, part of it is just that I know one day that there's a good chance I won't have hearing, and I was reminded that the longer I waited to use it, the less chance I would get benefit from it.
What do you hear now with the ABI?
More than I did before, and I can understand actual words, whereas months ago I couldn't, and I made Dr. Shapiro very happy. And I can actually understand words, however, it's just not as great quality as my hearing out of my right ear.
So in Dr. Friedman's slide, he mentioned, the range of success or the range of hearing with an ABI, and you seem to be at the high end of that range. You actually have speech perception without looking. You don't read his lips, and you can block your good ear, and you can hear words with your ABI. I think a lot of this, all three of you that have prostheses, speaks to something that we rely on a lot, and that's brain plasticity. You give our brain, it has to be a primitive signal. We're replacing 28,000 neurons in our cochlea with maybe 22 electrodes or 10 electrodes or whatever electrodes we're using, and our brain can still make sense out of that signal. And in your case, the more you use it, I think the more benefit you get.
Yeah, definitely. Yeah. I try to use it as much as I can, and a lot more than I used to. And so hopefully as I grow up, I keep using it more and more.
Thank you. So we're going to, just in the sake of time, I'd just like to each ask one more question to the group, and you can each answer it. And this is something I've been dying to ask patients for a long time. And haven't found an opportunity like this. So since you're all here, what do you think we could do better as clinicians and physicians in helping you? make decisions about your management of the NF2 and your hearing? Is there something you think that we're missing, that we as physicians who chose to spend our lives and our careers working in this area? Maybe Marianne?
Hearing knowledge of other people, that helps. I kind of wish that I had someone like me saying how wonderful this is. I mean, for me, I've been at NYU for 30 years now, and I mean we're getting the help that we need, but this forum is very helpful.
So we can congratulate Carol for organizing this every year.
Yeah, and I think this is great too. I think, there's so much new information coming all the time, and at some point you kind of have to turn that off. So I don't know how to improve that, filtering through, hey, something's come up since the last time I talked to you. So, we have to see so many doctors on a yearly basis, and some things like hearing kind of felt like a settled issue for me, but things are still moving along in ways that even if I've made some decisions, that maybe will change my decision. So I think that's one thing. I think the other thing, and this is just true, I think with doctors entirely, is I find that there is a lack of understanding of how to deal with hearing impaired and deaf patients, and I find that just really fascinating to me. The amount of telephone calls I've had cut off because the interpreter didn't answer the call in the time the person was expecting. I just find it really interesting how, or discouraging sometimes about how much I've struggled even to make appointments and deal with basic communication stuff just because they weren't getting a hearing person when they picked up the phone. So that's just
do many of your
general comment about the medical practice in general.
Wait, let's stay with you for 1 second. Do many of your physicians and caretakers allow you or work with you in using other forms of communication like email and MyChart? And do you find that helpful?
Yes, that's gotten better. Email, it's funny thing about email is there's HIPAA issues, and so some doctors have just decided to hell with it, and I'm going to email you in the way that works best, and other places get really iffy about that. And it's not NF2 doctors I'm talking about, it's all doctors. And so generally they've been good, but there have been situations that I'm always a little surprised at that don't have more training in terms of how to communicate and how to mode shift communication. I think that's really what it comes down to, that as a deaf person or a late deafened adult, as I'm mode shifting all the time, I'm using speech to text, I'm using written paper, I'm sometimes looking at your lips, and there just, I think, needs to be better training in the medical profession in general about how to navigate that.
Thank you. Jude, what can we do better?
I think it's pretty much to piggyback what everyone has said is communication. That's very big within the NF2 family. I believe this forum it's perfect for us. It brings us information we don't normally get on the outside. We understand what the doctors are saying. We understand it a lot better in a forum like this, where you get to meet others that's going through the same thing that we're going through. I look at it and I say, my gosh, man, I'm not as bad as I may feel. Things aren't as bad with me as it is with others, and it helps me, it motivates me. But then, there's 11 months in the year that, I don't get that same information I normally do. So if it's possible to get email updates when trials are available, I'm one person that's always willing to try something new. I really want to beat this. Also, when on a doctor's appointments, it's very disheartening when, you're sitting with a doctor and he or she may come in and, start talking away. I'm hearing impaired. You kind of have to be watching me. That should just be the obvious thing. I shouldn't have to tell you, you may need to start typing. Like I said, it's all about communication.
Thank you. Christine, you can wrap us up coming down the home stretch.
For me, it comes down to the fact that I'm on the younger side, and I think that it needs to be in consideration that I am younger and that I'm in college and I don't necessarily have all the time to do what somebody else might be able to do.
So we should tailor our suggested therapies and things that we're recommending to your personal situation.
I think so, and just understanding that I don't necessarily have the same amount of time, and that I also have more insecurities than some others might, just because I'm on the younger side, and that my peers don't necessarily understand, and they don't necessarily, they can be judgmental.
Okay, well, thank you very much. Let's give a round of applause for the panelists. Alon has one question.
Yeah. No, it's not a question. It's a comment, and it goes to Mary Ann's statement. The best market research I've done is sitting in the waiting room at the Cochlear Center or at your office and meeting patients who have 20, 30 years of experience and all the different devices. And when I was making various decisions with your help on what to do and problems afterwards or whatever, if I had an hour in the waiting room, I met all sorts of people that had a very wide range of experience and frankly found that to be pretty valuable.
Thank you.
So I'm going to give a real abridged version of this because I know we're way behind schedule. But like Carol said, my name is John Math. My daughter was diagnosed at age 7 and has had a really rough time since then. So we're very motivated as a family to do what we can to find a cure for NF2. So that's my daughter up there. She's 19 years old. She's currently in college. She's had 13 major surgeries, and I feel like this isn't loud enough. Is that better? So she had 13 major surgeries, and she has a sleeper ABI as well, and facial paralysis on her left side. So when she was diagnosed, we were told by doctors that there really wasn't a lot of treatment out there for NF2 other than surgery and possibly radiation. And since that time, we've seen just a huge influx in chemotherapy treatment. She's currently on Avastin and a combination of Avastin and Afinitor, and it's really stabilized her tumors, at least over the last year. So NF2 Biosolutions, I'm going to kind of go off script a little bit here because I did this presentation yesterday in Chicago. It was 45 minutes, so I promise you we're not going to do that to you. So NF2 Biosolutions is a nonprofit, just like CTF and NF Network and everything else. But our focus is very different. So we don't want to be redundant into what other organizations do. We want to do our own thing. And our focus is to be laser focused and concentrated on advocating for a gene therapy cure for NF2. And I'm just going to move ahead to a consortium we had. Well, first of all, our board of directors is made up of all parents and patients of who have NF2. And so we're highly motivated. We have no paid employees at this time. That's probably going to have to change at some point because we keep growing very, very rapidly. We do have a chief scientific officer. So this is Edgar Rodriguez Lebron, and he is very well known in the gene therapy scientific community, and he volunteers as our chief scientific officer. He's a chief scientific officer for Lacerta Therapeutics out of Florida. We have an incredible scientific advisory board, and I'm not going to go through all of them. All this is on our website, but we're international. We have people from Paris and places like that, and they're NF2 researchers, NF2 clinicians, and gene therapy researchers. This is just a kind of a cool story. This is Crizel. So Crizel has NF2, and she lived in the Philippines, and she was on our advisory board. She's also a medical researcher, and Crizel really wanted to work on NF2 research, so we were able to bring her to the United States, and she currently works at Dr. Meyer's lab at Nationwide Hospital, where we've started a NF2 gene therapy program. So it's kind of neat that she actually gets to work on hopefully finding a cure for herself and others with NF2. So gene therapy, we've been told by the gene therapy experts, is that NF2 is a very good candidate for gene therapy for a variety of reasons. A lot of it is genetic. I'm certainly not a scientist, so I will not even attempt to explain that. But it really, some of the other things that lend itself to it is we already have very good natural history studies. We have very good mouse models in NF2. So we've been told that those are big pieces that other conditions are missing that NF2 has. We have lots of challenges. We're still trying to create our core team of people. We've only been around for about a year and a half and really only active for a little less than a year. The organization was started by Nicole Henwood out of Philadelphia, and she's a physician whose son was diagnosed just about almost 2 years ago now with NF2, and she had done work in gene therapy prior to becoming an anesthesiologist, and she had a lot of connections, so she really leaned on her connections and to get a lot of this stuff rolling. So we're constantly looking for new ways to do this. So what is our strategy? So our strategy as an organization is to really advocate. We need to kind of connect gene therapy researchers with NF2 researchers and with patients, and those are all really important pieces. So we've had really fast progress, as you can see. So we started in 2018 as a nonprofit, and September of 2018, we really started our social media presence, and we've done most of our fundraising. The slide's a little old. We're at $500,000 right now raised just in 2019. So, and as you can see, we've progressed to the fact that now we actually have gene therapy labs up and running, and I'll go through that next. The first thing we did was we had to have a gene therapy consortium for NF2. So we piggybacked on a gene therapy conference that was going on in Boston for rare disorders. And we asked a bunch of the gene therapy experts if they would stay an extra day. And a lot of them said they would, about 10 of them did. And they were from numerous biotech companies and academic institutions. So when we told them what we wanted to do, they said, well, you need more than just us, you need NF2 specialists. So we started emailing our own doctors and people like that. So we ended up with a little over 40 people there from all walks of life. And this is what the room looked like, and it was actually super exciting. I was very energized watching this. So each table had a combination of a gene therapy researcher who probably knew nothing about NF2, an NF2 clinician or a surgeon or both, and an NF2 scientist, a researcher. And we posed different questions to them about how NF2 could be, how gene therapy could be used to treat NF2. And we came up with incredible answers, and how collegial it was amazing. And most of the researchers had never been to an environment like that, because most of the time there's committees and things like that, but this was kind of like something like Google does. And it was a full day. We worked them for almost 10 hours. So it was an exhausting day for them. And from that came a lot of exciting stuff. These are just some more, oops. All right, something happened there. Oh, clicked on the video. All right, well, I can just go off script here. So since then, we had two researchers come forward, two gene therapy researchers came forward and wanted to start gene therapy programs for NF2. The first one was at University of Massachusetts, Dr. Mueller, and he does something called AAV therapy, and he's in the process right now of creating a vector and for NF2, and once he creates that vector, he's going to package that. And one of the things that BioSolutions is going to do is then we will make sure that that gets sent to a certain NF2 lab that's going to insert that vector in the NF2 mice models. And then they'll be able to then, unfortunately, they'll have to sacrifice the mice and send them back to Dr. Mueller's lab, and they'll determine whether that vector worked. And so it's all in very early stages. Another one was Dr. Catherine Meyer at Nationwide Hospital, and the Nationwide is known as one of the leading institutions for gene therapy. And she uses a similar approach where they're going to kind of re-edit the NF2 gene. And I wish I could understand, I wish I understood it better to explain it to you. But the hope is that next year or the following year, we'll actually have researchers who can come and tell you about the work that they're doing. So Dr. Mueller's lab is very active. BioSolutions just funded 2 full-time research assistants there for the next 2 years, and they are in the vector production as well. The third one is Dr. Brenner from University of Massachusetts, from Mass General Hospital. And Dr. Brenner has a different approach, and he's already done this on mice with very good success. And his approach is a suicide gene, where he is going to insert the vector right directly into the tumor itself, which is problematic a little bit because then you have to have access to the tumor. And with mice, at least, it has eradicated the NF2 gene in the mice. So there's needs to be done what's called a tox study on that, and we're looking for funding for that right now through some major donors that we've applied to. So we're very active as an organization, and I know there's some confusion. We're on Facebook and stuff, and there's some confusion as to what we are doing. A lot of people think we're a biotech company, and we're nothing like that at all. We're just an advocacy organization trying to advocate for the NF2 community, and hopefully in the future that will lead to a treatment using gene therapy. So, and unfortunately, I won't be here for the panel at the end, but feel free to email me and ask any questions. So thank you very much.